Okay, everyone, this is your recorded lecture on Module 5, which is covering everything endocrine. So let's get started. The first problem we're going to be addressing is diabetes insipidus. So what this is if we're thinking endocrine, we have to think where the problem is originating. And this is a problem with the posterior pituitary gland because that is what releases the antidiuretic hormone, which is ADH, as well as oxytocin. So basically, any disorder that's related to the release of ADH could include something like diabetes insipidus. So diabetes insipidus is caused by a decreased secretion of ADH from the posterior pituitary gland if it's central. Now, you'll see in the textbook there's different types of diabetes insipidus depending on where the problem is occurring. So if it's central, it's a direct problem of the posterior pituitary gland because that's what secretes ADH. If it's nephrogenic, that's a kidney problem. So the kidneys are resistant to the ADH. They're not able to then concentrate the urine. So that type of DI is a little bit different. That's something we'd more likely see in patients with a chronic renal problem. Um, Basically, though, let's just go into the pathology of them being the same. I really just want you to think that there's a decrease or absence of ADH. So if that were to happen, we're having a problem with water. We're just excreting really large volumes of urine. It's very dilute. They're going to be dehydrated if we are losing that much. So it's just that ADH, now those collecting ducts, they just are not permeable anymore to water. That's why we need ADH to begin with. So again, it's just very large dilute urine that's being excreted. So that would make sense then that they're going to be thirsty, right? They're going to be voiding a lot. They're going to be voiding overnight. They're going to become hypotensive because of all that fluid volume that's being lost. So these symptoms really relate to the lack of fluid that they're losing. So any signs of fluid volume deficit essentially would result in this. Um, how you're going to diagnose them, you really want to obviously monitor their urine output every hour. And that urine output, the concentration of the urine is what we look at to determine the diagnosis of DI. So their urine specific gravity is going to be low. It's going to be less than 1.005. The urine osmolality is also going to be less than 200. It's going to be low. And we're going to see an increase in sodium. The serum, when we talk about osmolality, serum means blood. So there's different osmolalities. You could have a urine osmolality or blood. Excuse me. So serum osmolality and the hematocrit are going to be elevated because everything is so hemoconcentrated. So when you're studying these, you do have to know the differences in the lab values between everything. So you have to know the labs for DI. So you would want to know that the hematocrit is going to be increased in DI. You want to know the serum sodium is going to be increased in DI. And you want to know that urine specific gravity is going to be decreased in DI. They will do a water deprivation test also to diagnose them. Basically, they withhold all water and urine osmolality and body weight are measured hourly. During the test, the patient's weight and urine osmolality are evaluated because normally if we withheld water, it would lead to a urine osmolality 2 to 4 times greater than the serum osmolality. But in this case, it is DI because the serum osmolality continues to increase and there is no increase in urine osmolality. So that's abnormal. That's what makes us say like, oh, this is DI. So what do you guys think? if we're worried about them losing fluids, don't you think we would want to increase them? That's the main thing we're focused on. So management of DI is focused on maintaining adequate fluid. So if they're awake, maybe they're going to drink fluids, but in an emergency or if they're unconscious, you're going to do IV fluids. You're going to do hypotonic fluid like dextrose in water or half normal saline. And you're going to monitor them for hyperglycemia, volume overload, and you're going to correct that hypernatremia during this time. You don't want to ever change things really rapidly because we want to make sure our body is acclimating to the changes. So in these cases, like if the serum sodium was high, we only want to drop that a little bit every hour. And if we were to continue, what do you think we're going to do to treat it medication-wise? Well, we're going to use desmopressin. This is a synthetic analog of ADH. So this is the drug of choice for diabetes insipidus. You can give it multiple ways. They have it intranasal, oral, or subcutaneous. Um, and there's a synthetic type vasopressin, right? We talked about vasopressin before. It's a little bit less expensive. So if we're treating them with this, we need to make sure that we're monitoring their fluid status, still their electrolytes, and still their urine output. So make sure you're teaching the patients to weigh themselves daily. They should be reporting a weight gain of more than 2 pounds in a day, weigh themselves at the same time every day, keep track of their I&Os, and signs and symptoms of fluid overload like swelling or coughing. They should report those. So a lack of ADH would lead to excessive water loss with resulting decrease in blood pressure and an increase in heart rate because it's trying to compensate. So again, remember they're hypovolemic and they're dehydrated. So that's what we would see. So make sure that you're getting IV access. We're starting that half normal saline. You're giving them desmopressin. You're giving them oral fluids, daily weight, check their serum sodium. Because again, that lack of ADH is going to cause an increase in water excretion. So it's going to lead to an increased concentration of serum sodium. So they're going to be hypernatremic. And again, what is their urine specific gravity going to be? It's going to be low because they're excreting very large volumes of dilute urine. On the opposite end, if we think about patients with syndrome of inappropriate antidiuretic hormone, it's the opposite of diabetes insipidus. So this is a disorder that's related to an increase in ADH. So again, because ADH, the whole function of that is to reabsorb water in the kidneys. If we have too much of that, we're going to see fluid volume overload. So they're really overloaded on fluid. And as a result of that, they're going to be hyponatremic and they're going to have hemodilution. There's different causes for SIADH. It kind of varies. It can be sporadic, but anything like our central nervous system disorders, such as tumors in the brain or the neck, side effects of some meds like NSAIDs, um, trauma. If they were to fall down, like patients with a TBI may develop complications like this. Those patients would all be at risk for eventually developing SIADH. So this is diagnosed the very same way that DI is because this is an abnormal finding. So what we're going to be looking at is the urine specific gravity, serum sodium, urine osmolality, and their electrolytes essentially. So we really see hyponatremia when that sodium falls below 135 and their serum osmolality also drops. because the urine output is going to decrease because of the fluid retention. So if the urine output were to decrease, we're actually going to see an increase in the urine specific gravity and the urine osmolality. So that's what makes this different. It's unusual. This isn't what we should see. That's how the provider is going to say, oh, this is SIADH because these lab findings are abnormal. Because typically, if the patient were going to present with a little bit of urine, we would want that to see concentrated urine. We would expect to see dehydration. So when they're dehydrated, you expect to see elevated sodium, serum osmolality, and urine specific gravity. Those things should be high. But when you have SIADH, because it's related to the ADH secretion, it's the opposite. That urine specific gravity is different. It's elevated. That's abnormal. It's inconsistent, and that is how we know it's SIADH. So again, it's abnormal. You have to know the typical lab findings that you would be seeing with SIADH and DI. So if we're in fluid overload, do you think that we're going to restrict fluids or encourage them? Well, they're in fluid overload, so we're going to restrict them. We want to concentrate the serum sodium. So you have to come up with a plan. How are we going to distribute fluids to them throughout the day? So, and you want to really correct the hyponatremia. Usually with the fluid volume, they're usually restricted less than 1,000 mLs a day. And if the hyponatremia is severe, then we may have to replace that with 3% saline. But if they are getting 3% saline, that hypertonic fluid, they have to be monitored very close. And it's infused through a central venous catheter. It's typically not given through a peripheral IV. So again, I mean, it needs to be monitored really carefully, and you still have to really monitor them for fluid overload. Technically, you may try a diuretic to try and increase urine output, but that would depend. They also could try, there's a medication called declomycin, which is a tetracycline derivative that may be used to try and increase water excretion by the kidneys as well. So when you think of hyponatremia, you should, if we're thinking if their sodium level falls below 120, you're really concerned about seizures. So you would definitely want to implement seizure precautions. So those are what are going to increase with the serum sodium level that low. So there's really good charts in FA Davis. I would say make flashcards to help you remember the differences in the two, as this kind of outlines it really well. So you do have to know what vitals to expect with which diagnosis. So they compare these here. Here's the other lab findings you'd see. We have a nice little picture. They have some really good videos explaining the two as well, which we'll watch one in class. But again, remember, what might you see with hyponatremia or hypernatremia? So I do remember like our low sodium can cause headaches and confusion. So that might be something also that you see with SIADH. So I made some little cheats to help us remember. So remember, in SIADH, we're going to have low levels of sodium. We're retaining too much water. We're diluting the sodium in the blood. So again, we're monitoring for things like seizures, headaches. With high urine sodium, because even though we have low serum sodium levels in the blood, the kidneys continue to retain that sodium. So that would result in all that sodium actually being in the urine. So This all, again, that's abnormal. That's how we might know that this is SIADH. And the urine osmolality is high in SIADH. So again, urine osmolality is what measures the concentration of particles in the urine. So in SIADH, the kidneys are unable to properly dilute the urine, so it leads to higher than normal urine osmolality. So this, at the end of the day, it means that urine is more concentrated than it should be, indicating the retention of water by the kidneys. On the opposite end, diabetes insipidus, we see high serum sodium. Sorry. The body is losing too much water. So that is what leads the body to increase concentration levels of sodium in the blood. You have low urine specific gravity. So that urine specific gravity is what measures the concentration of solutes in the urine. And in DI, the kidneys are not able to concentrate it. So it's very low. And you have high urine output. Remember, your priority is to replace the fluid. So that's really the basis of DI and SIADH. So please write down any questions that you have on those. And we're going to get into adrenal insufficiency now. So these are all separate chapters in your textbook. But when we're thinking adrenal insufficiency, I want you to think of Addison's disease. So again, with Addison's disease, like this is similar to DI, how you can have an SIADH, you can have different roots of the problem. But in Addison's disease, it's a problem of the adrenal glands. So that is the main problem that we're seeing with this. When you're getting into these other problems, you could have secondary problems. So you could have a problem with the hypothalamus instead of the adrenals. That would be a tertiary problem. You could have decreased ACTH from the anterior pituitary gland. That would be a secondary problem. So adrenal insufficiency can be related to different areas of the body, depending on where the problem is occurring. But if we're talking Addison's, we're talking it's a primary problem of the adrenal glands. So despite the etiology, they all really present the same way. That's why let's just think of this as Addison's disease, okay? You're really going to see more females than males, and typically this peaks between 30 to 50. And again, you could have an autoimmune process that slowly really just destroys the adrenal glands. We also have to think about patients who are prescribed corticosteroids for longer than 2 weeks, and they would be at risk for things like acute adrenal insufficiency if they stop those steroids abruptly because your adrenals didn't pick up the cue and resume steroid production. So and any patient that's prescribed corticosteroids for more than 4 to 5 weeks will suppress that secretion of those hormones. So that could lead to adrenal insufficiency as well. Remember, at the end of the day, our adrenal cortex secretes cortisol. It's a glucocorticoid, so our steroids. So what you're going to see on these patients is different findings depending. But these presentations don't come about unless there's up to 90% destruction of that adrenal cortex. So basically what you can see this increase in the hyperpigmentation is what we call it. That picture, that's because with certain problems, there's just a really high influx of ACTH that's observed in adrenal insufficiency, and that causes that darkened bronze pigmentation that we would have seen in Addison's. And these patients also will have weakness, weight loss, fatigue, nausea, abdominal pain, depression, mood changes because of that lack of steroid. They can also have like decreased pubic and axillary hair just because they could have a reduction in those sex hormones. They do ultimately lose sodium and water. So these patients, similar to DI, can develop dehydration and hypotension. So you would be monitoring for that. So how we determine if someone has adrenal insufficiency is blood work. So you're looking at electrolytes. Like we said, they're probably going to be hyponatremic and hyperkalemic because of that decreased secretion of aldosterone. But with this, we're really also measuring serum cortisol levels with the steroid, right? So these have to be drawn first thing in the morning, because if I'm moving out and about, my cortisol level will automatically rise with stress. So these are done first thing in the morning. You don't have to memorize all of the lab values here. You just have to know that it's first thing in the morning. And we look at that 42.2. There's a chart, as you can see, that goes over the results. If that cortisol, it will be decreased in Addison's. So that is how we would know. You're also going to see that their glucose might be low. Like we said, the potassium could be high and their sodium is probably going to be low. So if I have adrenal insufficiency, if I'm not pumping out steroid, then we need to give steroid. That is the treatment. So the replacement of cortisol is the definitive treatment for adrenal insufficiency. Any patient with adrenal insufficiency, you have to think, since we're talking hormones and we're talking stress, if these patients are about to have a surgery or an infection, these patients are at increased risk for something called an adrenal crisis, because during those times they need more cortisol. So it would be life threatening if we did not give those clients more steroids in those times of stress. A lot of you will see things like IV hydrocortisone. It's also known as Solu-Cortef. That is a preferred medication that you would give. They would have to be closely monitored. You'd be checking their vital signs, their level of consciousness, again, their sodium levels, glucose, potassium. And remember, if someone does have hyperkalemia, then you could give something like Kxalate to bind to that to lower that potassium level. If we don't treat these clients, these are the problems that could present. So we want to prevent that, because we don't want them to go into an acute adrenal crisis. That would be a life-threatening emergency. So that is what would lead to that severe hypovolemia and hypotension. So again, these would be the patients that have adrenal problems. They have that hypofunction at baseline, and now they're in a stressful event like a trauma, surgery, or an infection. And because of that decreased level of that aldosterone and cortisol, now they're losing more fluid. They're losing more sodium. So that would be an emergency. They're also at more risk for hyperkalemia and hypoglycemia. So that is what we're monitoring for. So how we prevent this is, again, if anybody has Addison's, we want to give them additional doses of glucocorticoid steroids during those periods of stress to prevent that. The big thing here is teaching a lot of these clients. You have to teach them that they're taking their oral hormone replacements every day. They can't just not take that because their adrenal gland doesn't work. So we need them to be taking the replacement. They should wear a medical alert bracelet, especially if they go into a crisis, like an adrenal crisis, so that the provider knows that's the problem. They may need more salt and water in hot weather, especially in Arizona, just because we lose that from sweating. So they may need more salt to help maintain that. And the patient should know, as well as their family members, about early signs of adrenal insufficiency, like that could deteriorate into a crisis. So they should know the signs and symptoms of, let's say, hypoglycemia. We should also always remember, if I'm giving them corticosteroids, we want to remember our things can always have the opposite effect. So over replacement of those could include things like weight gain or osteoporosis. So we want to make sure that we have that right dose, that we have that correct balance there. So again, here are some more helpful tips on this. If we have the adrenal crisis, it's due to adrenal insufficiency. That's a very rapid onset, normally triggered by stress, trauma, or maybe we suddenly stopped our replacement therapy. They could present with altered mental status, confusion, and possibly coma due to cortisol deficiency, because that's what helps the brain function. Adrenal crisis, they may present with that hyperpigmentation of the skin, especially in Addison's disease, due to that increased level of ACTH that's circulating. The ACTH is what stimulates the melanin production. And again, it could be precipitated by stress, infection, surgery, trauma, or if they suddenly stop their meds. On the opposite end, if we have hyperfunction of the adrenal cortex, we're going to see the opposite. So again, this is something that has different subcategories, but basically we're going to be looking at Cushing's. So there's Cushing's syndrome. It's just this broader term that really just kind of umbrellas that excess production of glucocorticoids. Um, but you'll see there's Cushing's disease. And again, that's usually the condition by excessive hormone produced from the anterior pituitary tumors, or ACTH that's produced in excess, because maybe there's a tumor in the adrenal cortex. But at the end of the day, we're just going back to, there's some sort of problem that's causing this hyperfunction, and they're all going to present basically the same way, and our treatment is going to be the same way. So we know we just have excess circulating steroid. We have excess secretion of ACTH. So we're going to see that high steroids. What are you going to see with that? Of course, your blood sugar is going to be high then, because I'm having a lot of glucocorticoid released. So I'm going to be hyperglycemic. I'm going to retain fluid. My potassium levels are going to be low. I'm going to have abnormal fat distribution, and I'm going to have a decreased muscle mass. So it would be expected to see like a pad of fat on their back. That would be expected. You may also see virilization in female clients, which could mean male sexual characteristics being developed. You may see breast atrophy. They may lose their period. And again, when we have that overproduction of cortisol, it does affect the immune system. So it reduces their immune response. So they would be more at risk for things like infections. And that excessive cortisol really leads to osteopenia, bone breaks. They would be at more risk for bone fractures. It's the same way to diagnose this as if they were insufficient. So we need to assess their electrolytes. We're going to do urine specimens. Um, there is a different test with this. They do a measurement of urine. It's a free cortisol level. It's an initial screening tool that they do because it measures urine cortisol over a 24-hour period. So that is one way they could do it. They also could do an overnight, it's called a dexamethasone suppression test. And essentially, what they do is they give you medications. They give you dexamethasone at like 11 p.m. at night. They do this overnight, and then they collect a cortisol level at 8 in the morning, and they base the results on that. So they look at if it was repressed or not. So if that morning level is low, like 2 to 3, that would be normal. You again don't have to remember that. That's a little bit too much to look at, but basically they have these different evaluations that they can do, whether they're looking at the cortisol levels, they're giving them steroids and seeing how their body responds. There is a diagnosis section in your textbook on page 1004 that breaks these tests down a little bit more. So what would you imagine that the treatment was going to focus on? Well, we want to diagnose it first. We want to prevent those complications, right? If they are at risk for bone fractures, I want to help with that. Um, I want to give them a couple medications that can suppress that production. And these are the medications that we have here. So there's 2 different ones that are common. It's this aminoglutamide and pasireotide, which can be used to treat the overproduction. What they basically do is when they give these medications, like pasireotide, that's a injection, so it's actually sub-Q. And again, it just releases that release of corticotropin. And with any of these, if I'm treating that, then you have to monitor for the opposite effect. So you would want to look for signs of adrenal suppression. So if they all of a sudden were hypoglycemic, hyponatremic, or hyperkalemic, maybe I'm giving them too much medication. So that would be what you'd be looking for on the opposite end. And you want to prevent these complications. So if I don't treat this, these are the problems that can happen. You want to make sure that they're not in fluid overload. Manage the glucose level. Watch them for infections. We don't want them to get an infection. Monitor their vital signs, their skin, because that skin is going to be thin. Their wound healing is going to be delayed. So you'd want to be watching for that as well. So any type of change in body temperature would be something you'd want to report because that could be significant in these clients. Their blood pressure, heart rate, those might be a little bit high because they're retaining fluid. We want to evaluate trends here for anything endocrine as well. So monitoring their intake and output is important when I start treatment. Like I should be giving them the medication and now their urine output should be increasing. So I should be seeing a decrease in that fluid overload. So they shouldn't have crackles in their lungs. They shouldn't be short of breath. That would be a problem. Their glucose levels should be stabilizing as I'm doing the treatment. Their glucose levels should be dropping. Their weight, I want to continue with that daily weight. That weight gain would happen if they're retaining more fluid. They shouldn't have peripheral edema developing. Now, especially when I'm starting treatment, those things should be resolving. So please write down any questions that you have about SIADH, DI, adrenal insufficiency, or adrenal, anything adrenal. Thank you for bearing with me, everybody. I am a little bit under the weather, as you can see, but I'm trying to get through this as best as possible for you. So what we're going over next is thyroid problems. This is a separate part in your textbook, okay? So we're actually going to start with hyperthyroidism, and then we will go over hypothyroidism afterwards. So with hyperthyroidism, this really can be present at any age, but this is something that's more common in females between 20 and 40. And again, it's 10 times more prevalent in female clients. So Graves' disease, that's the most common one that we see. It's autoimmune disorder, and it involves antibodies that kind of bind to that thyroid gland, and that is what results in enlargement of the thyroid gland, and there's a hypersecretion of thyroid hormone. So basically, what we think about here, if we're thinking hyper, we're thinking accelerated. So there's an accelerated metabolism. That's a real key characteristic of hyperthyroidism. And this really affects like every body system for them. There's primary hyperthyroidism. Um, that is secondary. There's excess T3 or T4, and that's released from the thyroid gland. If we have increased TSH, that's the thyroid stimulating hormone, that is when we develop secondary hyperthyroidism. And there's also tertiary hyperthyroidism. So there are different branches, again, for all of this. And what you'll see are different lab results depending on the subsequent type of hyperthyroidism that we have. So we will go over that. But your symptoms here kind of make sense again if we're thinking of that hypermetabolic state. So they're going to lose weight, they're going to be hot, they're going to lose their hair. They may have dysrhythmias. They may have increased bowel movements. And another common thing that we might see is when their eyes are bulging. Remember, this is termed exophthalmosis. And that's a characteristic of hyperthyroidism, and it will result in visual change. They may have goiter too, that enlarged area in their neck. That can be associated with hyperthyroidism just because there's that overstimulating response in the TSH. So how you're gonna diagnose this, the client comes in and they're like, I can't sleep, I'm anxious, my heart feels like it's pounding, I'm eating things, and everything is I'm just losing weight and I can't stop it. So those would be a key indicator. Okay, I want to do some lab draws on these patients. So they typically will draw the thyroid studies. So what you're going to look at is T3, T4, and TSH. So there is a table, 43.2, and I do have it attached in this PowerPoint, but that goes over your labs and if they're increased or decreased in the function. So you do have to be able to identify that. So if we had T3, that's going to be increased in hyperthyroidism. Your T4 is also going to be increased. Your TSH, that thyroid stimulating hormone, it depends on if this is a primary hyperthyroidism or not. If it's coming from the thyroid, what's confusing is it's actually going to be decreased because of that biofeedback system that's going on. So in primary hyperthyroidism, the TSH is low, but the T3, T4 are high. If it's tertiary hyperthyroidism, then your TSH is going to be high as well. So I would just make flashcards to try and remember that. We can do scans also if they have the goiter is when that we see that enlargement there. But we would have a pretty good indicator alone with just the lab values that we will see there with the hyperintolerance and everything like that. So, and if they're complaining of eye changes again, we probably would know that. So what do we want to do? Well, we drew the labs, we saw that elevated T3, T4, and that reduced TSH. And so we know that we want to slow things down. So we want to control that hypermetabolic state that's going on. So we want to treat the symptoms. If they're having dysrhythmias, we want to identify that. We want to treat their body temperature. Those are priorities for sure if they're elevated. That's why we want to promote that non-stressful environment for them. Um, and we want them to be relaxed. There are medications that we can use for like long-term management of hyperthyroidism. They use anti-thyroid meds that are listed here. That includes the PTU, Tepazole, and lithium. Those medications really are going to reduce any of those clinical manifestations that they have. They're going to interfere with that formation or release of the thyroid hormone. If it's a short-term management, we might use iodine preparations, especially if this patient's going to need their thyroid removed, because we want to decrease blood flow in that area. Um, so there is precautions though, if they are getting that iodine treatment. Box 43-1 on page 1018. Like these patients have a lot of restrictions. They can't prepare food for others. They can't share utensils. They can't travel by plane. They can't be in public places. So that is why the iodine preparations are really short term. The beta blockers could just relax their heart rate if it's beating really fast. That would be more for symptomatic relief. Um, when it comes to like PTU and Tapazole, basically they just have to they have to take that med the same time every day in the mornings, and they should monitor their weight 2 to 3 times a week. We would want to teach them again the opposite, the worst case scenario of effects from those meds. So what are the signs of hypothyroidism? Because I don't want to give them too much medication. And we do want them to monitor their white blood cell counts. We would want their labs drawn because a granulocytosis could occur. If we do a thyroidectomy, again, they're going to have to take thyroid replacement hormone for their whole life. The main complications we would be looking for here would be hypoparathyroidism could occur, so we'd have to treat that. And if they're going around here, you can think of how sensitive this area is in the neck. It would affect the swallowing in their voice if they were to damage the laryngeal nerve. So the big thing for you all is to monitor them post-op. So we have to know what complications could they have after. So the post-op priorities, if they have a thyroidectomy, would be monitoring the airway. We want to make sure there's no compromise there. Hemorrhage, we don't want to bleed. The hypocalcemia, like I said, could result if we remove the parathyroid glands, and we could damage that laryngeal nerve. Hemorrhage is most likely to occur in the first 24 hours, so you want to observe for bleeding around the dressing and the back of the neck. We may use sandbags to help keep the head in proper alignment, and you want to make sure repositioning them is very careful. If there was bleeding, you would need to apply pressure right away. When they are post-op, we position them semi-Fowlers just to reduce that. We want to make it easier for them to breathe, and we give them humidified air for the secretions. We would keep a tracheostomy tray at the bedside because of swelling. We don't want airway swelling. Hypocalcemia, remember, a symptom of that is tetany when they have those muscle spasms. So you would be monitoring for that as well. Um, and if you noticed any changes in their voice, husky, they're hoarse, that could be indicated of laryngeal nerve damage. So we would do voice assessments every 1 to 2 hours immediately post-op for them. A thyroid store that can develop if we have hyperthyroidism and we were not taking our medication. We were not treating it well. So this is worst case scenario for them. They're going to come in really tachycardic with a fever. Their blood pressure is going to be really high systolically. Their stomach is going to hurt, and there could be changes in level of consciousness. In these clients, your airway management is the priority, and you want to give them fluids. You want to give them antithyroid medications right away, and you probably are going to give them iodine because of how quick that will work. Remember, therapeutically, if I'm trying to treat an overproduction of thyroid hormone, I need to give them medication that stops that production. So that is why giving them like methimazole would be the first intervention that I'd really want to do alongside treating the symptoms that they're having. If they're tachycardic, again, I might give beta blockers to reduce that. Um, Maybe I'm going to do glucocorticoids as well because they do help convert that T3. So it might help with that. And if they're febrile, I'm going to do cooling blankets to treat that hyperthermia. Um, and you're really monitoring them closely for seizures, cardiac problems. Whenever we do cooling or if we're even warming up a person, you always have to do it slow and their temperature would have to be monitored continuously. Because again, it's all about balance. We don't want to just flip the switch and now have it on the total opposite end. Always to remember the eyes because their eyes are going to probably be dry. So we might want to do some, eye drops. Here is that chart for the medications, an example that you guys can review. And now we will start hypothyroidism, which is really just the opposite of hyperthyroidism. So again, this though is more common in women than it is men, same age range typically 30 to 60. And now our thyroid is just not working. So now we're seeing a reduced metabolism. In the US, I mean, hypothyroidism is usually autoimmune. It could be they had the thyroid removed, or maybe because of the radioactive iodine. Um, so you'll hear that term like Hashimoto's. That's the most common type of hypothyroidism. And that's that autoimmune response. So it basically is just that destruction of the thyroid gland. So what you'll see here are different labs as well, depending on what is causing the problem. Um, but at the end of the day, the decreased metabolism, that's really the hallmark of hypothyroidism. And again, it affects everything. So when we're talking primary hypothyroidism, it's a result of the thyroid gland. If we're talking secondary, it'd be a problem with the pituitary gland. And tertiary is like a lack of thyroid hormone from the hypothalamus. So they're separate entities for the problem. Um, so depending on the gland, that will make a difference on if it's increased or decreased. So if we're talking primary hypothyroidism, then that TSH is elevated. So it's the opposite because of that feedback system. So we have low T3 and T4, but we have high TSH. If we are thinking Hashimoto's, which again, we commonly are here, then you would do a test of the antithyroid antibodies to diagnose them. This just kind of breaks down, again, the site of the problem, if it's tertiary, secondary, or primary. But no matter what, you're going to see the same type of symptom. So if everything is hypometabolic, my energy is going to be low. I'm going to want to sleep all the time. I'm going to be cold. I'm going to not necessarily want to eat, but I'm gaining weight. Um, I'm cold all the time. That could definitely be something that we see in hypothyroidism. I did attach a video. I think the video helps explain the lab results a little bit with like visuals. So, but again, if I'm talking hypothyroidism, if it's primary T3, T4, TSH, those are the labs that I'm really looking at. And if it's primary, that TSH is elevated. Um, Again, it's that result. There's that feedback system. So there's a feedback system to the hypothalamus and the pituitary, and that is why I'm having low levels of T3, T4. So what I want to do here is treat it with Synthroid. So if I'm having low thyroid hormone, I need to replace the thyroid hormone. So you have all learned about levothyroxine. Okay, you have to know this is the most commonly prescribed med for hypothyroidism. They started at a low dose and they're going to titrate it up to treat the symptoms that they're having. Um, so because it affects metabolism, that's why they take it first thing in the morning before they eat. It's lifelong, right? They can't just stop this. They have to take it the same time every day. They should always inform their provider that they're on levothyroxine as well. If they have a history of like cardiovascular disease, when we increase this, we have to do it very cautiously because I don't want to cause dysrhythmias or heart failure or chest pain from that increased rate that could happen. The worst case scenario for these patients is a myxedema coma. That would be the most severe type of hypothyroidism that we would see. And that's really characterized by their coming in, they're hypoxic and they're retaining CO2, the carbon dioxide, because they're hypoventilating. Their fluid and electrolyte imbalances, and they're really hypothermic because of that significant decrease in their cardiac function. um, they're really bradycardic and they're hypotensive. So they're hypoglycemic, they're hyponatremic, and because of that significance in the hypothermia, they're really sensitive. So they're very sensitive to sedatives, analgesics, and any anesthetics because they're metabolized so slow. So we have to be extra cautious with how we treat them as well. Um, so we may do something it's called interval doses, like they may adjust the dose of the medication that they're giving to see how these clients are doing with it. But at the end of the day, we want to replace the thyroid hormone and we want to treat the symptoms that they're having. So if they're hypoglycemic, we want to get their blood sugar up, and we want to replace the thyroid hormone that is not being given. So here is a good picture of what we can kind of correlate the myxedema with. You can see like that fluid collection that can happen in their face. They could be constipated, their abdomen can get distended. These clients can be cold, they're not sweating, their hair's lost, they're thinning. And then here is a picture of that. The goiter can be found in hypothyroidism as well as hyperthyroidism, so that can be confusing. But goiter is very common with hypothyroidism. So this is just a picture of a goiter. So again, what is the most commonly prescribed med for hypothyroidism? You should be thinking Synthroid. And think of all your education that goes along with Synthroid. Can they just stop it tomorrow? No, they cannot. They have to take it forever. So here's that chart I was talking about with the lab values. And here are some helpful tips again on this. So again, if we're thinking myxedema coma, we're thinking a deficiency of the thyroid hormone because they're so severely they're in a very severe state of hypothyroidism. So it's gradual. This wouldn't happen all of a sudden. they were just not treating the hypothyroidism, or maybe they're in an extreme illness or extreme cold that could precipitate something. So they could come in with stupor, coma, and again, that hypothermia because that metabolic activity is so slowed. So please write down any questions that you have about thyroid, whether that be hypothyroidism or hyperthyroidism. But again, your book has this outlined really well with the teaching and your nursing actions and interventions. And again, I really like the charts. Now we're going to get into diabetic ketoacidosis and HHHS. So this is again in a separate part in your textbook. It's in chapter 44. So if we're talking about um, DKA, I do want you to think back to your typical diabetic management. We're not going to review everything, okay? I mean, your DKA starts on page 1038 in your F.A. Davis book. So you do have to remember some of the basic logistics of your insulins because that is the treatment that we're going to be doing. So if we're talking diabetic ketoacidosis, this would be a bad thing that the client could develop. Basically, what we'll see is there's not insulin for cells to obtain adequate glucose. So we're not metabolizing glucose normally. So the body instead is trying to get all this energy from fat stores. And this is not where we want to get energy from. So we're end up releasing all these fatty acids. So the liver kicks in, it starts converting that acid, that fatty acid, into ketones. And that is the energy source that the body is now using instead of glucose. So ketones are not what we want to see. They have a really low pH and they will result in metabolic acidosis for the client. So we're just not functioning appropriately. We're going to see really severe hyperglycemia and it's not intended. And this is more common in our type 1 diabetics, so like a new onset type 1, or maybe our clients unintentionally miss their insulin dose, or maybe they're under stress or an infection and they actually require higher doses of insulin than what they are giving themselves. And then they can go into diabetic ketoacidosis. So the presentation is very similar to diabetes. The three Ps, that polyuria, polydipsia, polyphagia. Um, but now they're also getting dehydrated. They have electrolyte imbalances. They could be hyperkalemic or hypokalemic, depending. They're going to have shift fluid spacing, so they're like hyponatremic. It's just a lot is going on, and they're really at risk for hypovolemia because they're diuresing so much. So if we don't treat this, they're going to really quickly become hypotensive and tachycardiac because, again, that hypovolemia. Very particular with this is also it's called Kussmaul respirations. They're really rapid and deep, and they're trying to compensate for that level of acidosis that they're in. So you'll actually smell it's like fruity. There's acetone smell to the breath because of all those ketones that they're eliciting. These patients may have abdominal pain. They may be vomiting. They could develop lethargy and they could go into a coma if we don't treat this. So to diagnose these clients, you're going to see blood glucose greater than 250. Um, you're going to see ketones. So the ketone urea, that's ketones in the urine. You're going to see a low pH because they're acidotic. Their serum bicarb is also going to be low, and they're going to have a positive anion gap. An anion gap, it's calculated in the system, but that is something that it'll actually say anion gap on there. And the normal value is like 4 to 12, like we would give that to you in the chart. But if we say it's open, it's high. So we wouldn't want that anion gap to be high. It's all related to these ions that are going on. It's like chemistry calculation. Um, it's all positive because there's so many ions that are where they should not be. So it is elevated. So when we are talking as nurses, we're saying we're trying to close the anion gap. So as their condition improves, that anion gap is going to get normal. So that is one of the lab draws that you're obtaining when you're treating someone with DKA. So your treatment priorities are really to give them fluid. We want to use isotonic normal saline for them. We want to correct any of those electrolyte imbalances. So you're going to correct if they're increased or decreased potassium, you want to address those. We really want to try and address that before we start our insulin. And insulin we have to give, and it's going to be given through their IV. The fluid replacement is really essential because we have to correct that dehydration that's going on. And we want to avoid dysrhythmias related to the potassium imbalances. So, and insulin, we have to give that to correct the hyperglycemia. If they're hypokalemic, we want to give them potassium. We have to remember as we give insulin, um, in to decrease that hyperglycemia, the potassium is going to move back into the cell walls, which would worsen hypokalemia. So that is where, like, if they're hyperkalemic, sometimes we give insulin to treat that. So you really have to maintain the potassium levels really carefully. Because again, if I'm giving too much, I can result in more hypokalemia. So the big educational piece with DKA is that we're educating them on ways to avoid it. So there's sick day rules for people with diabetes, because they just sometimes people think if they weren't eating that they're not going to take their insulin, and that's actually not what we want to do. Um, we want them to really monitor their glucose levels frequently if they're ill. So if with DKA, if it's untreated, that can lead to death. So DKA is most common again with people that are type 1 diabetics and they're sick. So we want them to be monitoring for signs of DKA. So if they have elevated ketones, if their glucose is elevated, if they're nauseous, vomiting, confused, they're frequently voiding, they notice that fruity breath, that they would contact their provider right away. And if they're planning like an illness, that they plan ahead, so they're getting vaccinated so that they're trying to prevent that. Um, so we do treat them those signs. We have them educated on monitoring their glucose. So every 4 hours, if they're sick, um, that they don't stop their insulin when they're sick, that they still take it. And I just wanted to see on here. And we'll kind of go over more education on DKA in class as well. We'll do some activities together on that. On the opposite end, if we were just talking about complications associated with type 1 diabetes, now we can go into complications more commonly associated with type 2 diabetes, which is this hyperosmolar hyperglycemic state, which is HHS. So this is also very serious. This is actually more deadly than DKA, and it's more common in clients with type 2 diabetes. So in this case, they're very hyperglycemic, and they're dehydrated, but they don't have ketones. They don't have that ketoacidosis going on. Um, so there's just not enough insulin to help. So it is a difference in severity in the magnitude of dehydration, ketosis, and acidosis, because this, again, is more severe because it usually happens in clients that have a lot of comorbidities, like are elderly and they have an infection. So infections are the most common preceding illness for HHS, and it can be really difficult to differentiate that from something else. It is less common as well. So the diagnosis is a little bit different than DKA, because this you're going to see much higher levels of glucose. It's going to be like 600 or higher. Their serum osmolality is really high. They're really dehydrated. Their pH is actually elevated. Their bicarbonate is elevated. They don't have ketones, and you will see a difference in their level of consciousness. They could develop into a coma or confusion. They have like global neurological defects going on, and they have really severe electrolyte imbalances. So the first thing that you want to do, a lot of students think that you want to give insulin right away. You actually want to treat this with fluids because that dehydration is so significant. So your priority treatment for HHS is fluids. We want to correct that dehydration. That'll help their altered mental status, and you want to manage their airway. They may respond to fluids alone, but if not, you may have to give IV insulin. But again, your primary treatment is just going to be fluids, and that alone should help and treat the underlying infection that's causing the HHS. So there is a chart in here that goes over the difference in findings. You should know these. You should be able to say, oh, are they in DKA or are they in HHS? So again, your DKA is more in type 1 diabetics, but it can happen in type 2 diabetics as well. But this is really rapid onset. You're going to have ketones. The blood glucose levels are, 250 or higher. You're in a state of metabolic acidosis. They have that fruity breath, those Kussmaul respirations. And we want to treat this with fluids and insulin. These patients are in an ICU. And if I'm doing an insulin drip, I'm changing it every single hour. We're drawing glucose levels. A big thing with this in general too is we never want to reduce their blood glucose like really, really fast. You want to do things gradual. So a good rule of thumb is that we only reduce glucose levels by about 10% every hour. So again, you really want to replace those fluid volumes within 36 hours that they presented and reduce that glucose level by 10%. And again, to prevent that DKA, drink 2 to 3 liters of fluids, check your glucose every 4 hours when you're sick. And we want to tell them to check their urine for ketones if their blood glucose is above 240. If we're giving either of these clients insulin, they have to be on a cardiac monitor because of the risk for dysrhythmias. And since in DKA, they're acidotic, we're only going to see metabolic acidosis in DKA, not HHS. That is two of the big differences there. If we go back really quick, if we're thinking adrenal insufficiencies, what are your risk factors for adrenal insufficiency, like going into a crisis? Again, you stopped your steroids, trauma, sepsis. Those clients are going to have that muscle weakness, that hypoglycemia, dehydration, low blood pressure. Their oxygen's going to be the same, but their potassium might be high. So if they're in a crisis, what do I need to do? I need to treat that with steroids. I want to give them IV hydrocortisone. Um, give them insulin if their potassium is high. So make sure their calcium is normal. What's the priority with HHS? Fluids, normal saline. I want to give them 0.9% normal saline because, and you can see their labs, HHS, that osmolality is greater than 320. It's high. So when you're studying these, look at what are the symptoms that they have, because they're always going to be opposite. That's why students get confused. So what's the treatments for both of them? What are the symptoms? What's your priority treatment? When we're thinking priorities, you can also think like, if I'm in adrenal insufficiency, my priority is to give them the medication that treats that. That is why we would give steroid, because they're not making steroid. So that is why with DKA, we do want to give insulin because they don't have enough insulin. So know the medication that's really pertinent to that problem. No, do I give fluids for SIADH or do I restrict them? If I'm in SIADH, I have way too much fluid, so I need to restrict it. If I have a really low sodium level in SIADH, I need to monitor that. I need to make sure they're not having seizures. I need to understand that headaches and confusion are common symptoms of low sodium. So know your lab findings in both. If I'm using iodine treatment and hyperthyroidism, know the education that might come with that too, like how they couldn't travel or anything. And when they're using iodine, they definitely could be nauseous. So I would educate them on that. They could have like a metallic taste in their mouth. They could vomit. And that treatment, that'll take about a month for their symptoms to subside. So we want to make sure that those clients are hydrated, increasing fluid during the day to help flush out that radioactive iodine from the body. If there's a thyroidectomy, what are their post-op problems? Remember, bleeding can happen within that 24 hours. So if you notice the bleed, you're going to apply pressure right away, and you're going to immediately notify any type of sensations around the mouth because of that laryngeal damage with the airway. So if they were like, I'm numb or tingling, or their voice is hoarse, you would want to notify the provider right away. So please write down any questions that you have. We will go over this in class next week. And thank you for bearing with me throughout my sniffles. And just let us know if we can do anything to help.